Welcome to OncoPharm. I'm your host, John Mazzaro. I am a professor of pharmacy practice here at the ETSU Bill Gatton College of Pharmacy. It is February 19th, 2026, and we're going to talk about perioperative enfortumab vedotin and pembrolizumab in bladder cancer. This was discussed as part of our ESMO recap back in the fall of last year. We have the publication now of this study, which is EV303 or Keynote 905. By the way, Keynote, they're going to be above 1,000 soon. I'm going to call it like Keynote 1K1 for 1,001. Well, they say Keynote 1,001. That's what we're waiting to find out. Now, so this regimen of perioperative enfortumab vedotin and pembrolizumab in bladder cancer was approved by the FDA in November of 2005. So we had, the shell listed. We get the full publication now. So let's talk through some of the implications of this. We'll go over the data again, although there's not a ton of new stuff here in the publication that I can see or that's unexpected. So perioperative, when you hear perioperative treatment, that means both neoadjuvant and adjuvant. That's kind of what it means. Sometimes it's called sandwich approach, right? Sandwich, you got bread on both sides of, of peanut butter or ham or whatever. So sandwich, you got drugs on both sides of surgery. So in this case, it is 3 cycles of enfortumab vedotin and pembrolizumab, with pembro given every 3 weeks. So 9 weeks of treatment, then surgery, and then another 6 cycles of enfortumab vedotin and 17 cycles of pembro. Basically, another 4 months of EV, enfortumab vedotin, and 6 months, or basically a full year of pembrolizumab in total. So that's the design of this study. Now, it is in cisplatin-ineligible patients. Big picture approach for bladder cancer, you could just cure them with cystectomy, with surgery. We know that neoadjuvant cisplatin-based chemotherapy is better with having pathologic complete response prior to surgery, making the surgery more successful and associated with better event-free survival, living longer without your bladder cancer coming back. Now, bladder cancer, like so many solid tumors, is a disease of the elderly, and many of these older folks are not candidates for cisplatin based on poor renal function, performance status, hearing, heart failure, etc. So there really is a huge unmet need to try to treat these patients better. It's a little bit like spending a whole bunch of time trying to cure 30-year-olds with AML and neglecting the 65-year-olds with AML, which is the most prevalent population of that disease. That is the case for bladder cancer. A lot of these folks are not cisplatin eligible. So they are specifically looking at patients who are cisplatin ineligible, which is the FDA approval, but you'll see they're about 15 to 20%, which I didn't know from the FDA approval. They're up to 16, 17% of patients in this study who actually are cisplatin eligible, but they declined to receive cisplatin. So these patients, they get their treatment, or they're on the control arm, and they get surgery, a radical cystectomy. I am going to link to a nice comment, or it's a JAMA Oncology patient page about urinary diversion. So that's what happens. The bladder's there for a reason. It's got to store this urine. So it sounds pretty easy to cut out the bladder. I mean, to a pharmacist, it sounds easy. Cut out the bladder, boom, you can be cured. Well, you still need a way to house urine. So there are 3 main ways to do this. And the images are helpful on this link you'll see in the show notes. One is an ileal conduit. I think this is the most common surgically. It's the easiest. You take a small part of the small infection, you take your ureters, connect it to that, and then that small intestine pouch is connected through the skin via stoma that connects to a bag that fills up, and then you dump it. So that's surgically, I think that's the easiest thing to do. But you have to bag your own urine for the rest of your life. The other approach is a neobladder, and this is where you take some small intestine, patch together with whatever is left of your ureter, and connect it to the urethra. Now, small intestine is not designed to hold urine. So one of the problems with this is it's a neobladder, but it doesn't have the same ability to expand the way urothelial tissue does in a bladder. So there's a limited volume, so there's a more of a risk of incontinence, especially at night or like long car rides, for example. And then there's a continent cutaneous pouch, which is also known as the Indiana pouch, where you take some large and small intestine, piece it together, and have a stoma, but then that stoma you can catheterize it, so you can self-cath via the stomach rather than having a bladder, or rather than having a bag. So none of these are great. So I say all that to say there is a lot of interest in ways that could be bladder preserving, where you don't have to do radical cystectomy. And that may be where we are going with this. All right, back to EV303. Again, many of these patients with bladder cancer are not eligible for cisplatin. This is using the Galsky criteria, which is a creatinine clearance less than 60, although some of the French studies and European studies in bladder cancer, they use an inclusion criteria of creatinine clearance greater than 50, not 60. And in fact, in some of those studies, if they're not 50, they actually do a 24-hour urine or even below 50 to see if they are candidates. So we'll simplify it. Poor creatinine clearance, performance status of 2 or higher, New York Heart Association class 3 or 4 heart failure. You got to be able to handle some fluid to get cisplatin, right? Grade 2 peripheral neuropathy or hearing loss. Now we know that enfortumab vedotin and Pembro had a huge magnitude of benefit in the metastatic or advanced setting for first-line treatment of bladder cancer if you're cisplatin eligible or ineligible. This study specifically are those folks who are either cisplatin ineligible or decline cisplatin for other reasons. What I did not know about this study, about EV303 until the publication, is the initial design was perioperative Pembro versus control. And they actually changed to add a third arm, which was the enfortumab vedotin Pembrolizumab arm, which we have now. There was a second protocol change, actually to stop enrolling people just on Pembro and to to prefer the assessment of enfortumab vedotin and Pembro versus control. If we look at our patients here, they're kind of what you would expect for bladder cancer in patients who are cisplatin ineligible mostly. So, more than 40% of folks are over the age of 75. About 40% are 65 to 75. So older patients, 75 to 80% male. 13% of patients in the study were ECOG2. In most studies you look at in oncology, most randomized controlled clinical trials, it's going to be like 80%, 90% ECOG 0, 10 to 20% ECOG 1. That's who enrolls on clinical trials. Here it's 60% to 55% ECOG 0, 28 to 30% ECOG 1, and then, like I said, 13, 14% ECOG 2. So very representative of the real world. Most of these patients were from the European Union, 45%. About 80% were white, and 16 to 20% were eligible for cisplatin, but declined for personal reasons. About 50-50 between composite proportion score PD-L1 expression of less than 10% or more than 10%. So composite, that's PD-L1 on the tumor and immune cells. 17-18% were T2 muscle invasive bladder cancer. The rest were either T3, T4, or had nodal involvement. I point that out. That means at least 80% of people on this study would have been eligible for adjuvant pembrolizumab or for adjuvant nivolumab based on Checkmate 274. Now that study showed disease-free survival benefit for a year of adjuvant nivolumab. With full analysis, did not show overall survival benefit in the entire population, but in a subgroup that was PD-L1 positive. There was a trend towards OS benefit for everybody, but based on how they split their alpha, it was just an OS benefit in those that were PD-L1 positive, more than 1%. I point that out because it will be a potential critique of this study, is you had 80% of people who could have been candidates for adjuvant nivolumab, and on the control arm, that was only about 18% of people got adjuvant nivolumab, which is low. 90% of these folks were plain garden variety urothelial carcinoma with no variant features. The median time of follow-up here is 25.6 months, which is an important context when we look at our results. So the primary endpoint here is progression-free survival. Our hazard ratio is 0.4. It's a long way from 1. 95% confidence interval, 0.28 to 0.57. Very, very large benefit. Very easy to see the benefit. You can fit about 13 laser pointers between our PFS curves for our event-free survival curves here. I will point out the 12-month estimated EFS. So this is either the cancer came back, they died. The 12-month EFS with enfortumab vedotin Pembro is 77.8%. A year later, it's 74.7%. So you're going from 78 to 75. So there's not a ton of relapse or death that you're seeing in a year. To contrast that, the control arm, which was probably undertreated, not getting adjuvant nivolumab, was 55 down to 40%. So very, very big magnitude effect as far as preventing this cancer from coming back in folks that got surgery. And by the way, most folks did actually get surgery in both arms. We do also see a statistically significant improvement in overall survival. So our hazard ratio for overall survival is 0.5, slightly less impressive than the event-free survival. 95% confidence interval is 0.33 to 0.75, somewhat wide. Our 12-month overall survival estimate for 1 year is 86% versus 76%. It's actually a delta of 10.6%. And then from 1 year to 2 years, they're all done with treatment on the enfortumab vedotin arm. That delta is now 16.6%. So we're seeing this impact, this relative impact, grow over time, which is suggesting that we're not just delaying recurrence, but actually probably preventing some recurrence. And looks like we are curing some more folks with this, which is always encouraging, right? So our 12-month OS estimate is 86.3 to 79.7 at 24 months. And again, the median follow-up is 25 months. So we're seeing a good portion of patients in the study at that 24-month estimate. And that's impressive. The EFS benefit is impressive. The overall survival benefit is also impressive. Perhaps the most impressive thing on this study, and you could argue that OS benefit, really you'd like to see 80% of people on adjuvant nivolumab in the control arm instead of 16%. What would that do to that overall survival benefit, that event-free survival benefit? Even if you were doing adjuvant nivolumab, what would not change is the impressive results in pathologic complete response rate. So the pathologic complete response rate in the control arm was 8.6%. So maybe there is some, with the TURP, they're getting some perioperative gemcitabine or something like that. But the pathologic complete response rate with three cycles, so actually 6 doses of enfortumab vedotin, because it's day 1 and day 8 of every 28-day cycle, and 3 cycles of Pembro, is 57.1%. 57 versus 9%. So huge improvement in pathologic free survival. And there is an editorial that accompanies this publication in the New England Journal of Medicine written by a urologist who's talking all about trimodal therapy. It seems to be like just taking it in a different direction. Now, I mentioned the urinary diversion surgeries, and that none of them are what you would call like the perfect surgery for somebody with bladder cancer. It's not like like a mastectomy where you can remove a breast and then you can do breast reconstruction and have reasonable quality of life and function there afterwards. It's a little bit different if you remove the bladder as a vital organ. So there's a lot of interest in so-called bladder-preserving approaches or trimodality treatment, where you are doing a local surgical resection, a transurethral resection of bladder tumor. It's a maximal TURP, and some concurrent chemo and radiation. So if you're able, in more than half of these patients, to have all of their bladder cancer go away, do you really need to do cystectomy? Are some of those patients actually cured with their neoadjuvant treatment? And if not, can you, instead of doing a cystectomy, do a partial cystectomy or just a resection of where that bladder tumor was? Is that possible? And there are future studies looking at neoadjuvant, enfortumab vedotin, Pembro, followed by trimodality therapy instead of cystectomy. And one of the things that editorial points out is we don't know what's going to happen when you give radiation to a bladder that's already seen some pembrolizumab and enfortumab vedotin. Now, I was critical of the fact that there wasn't enough adjuvant nivolumab in the study. The authors do point out that based on where adjuvant nivolumab was approved and available, it was kind of hard to be higher than that. If you look at our forest plot between the U.S., European Union, rest of the world, you're not seeing any differences there, which maybe you might expect less relative benefit in the U.S., assuming more of those folks would get adjuvant nivolumab. Our safety profile is pretty much what you would expect for enfortumab vedotin, with some hyperglycemia, a lot of skin toxicity, the neuropathy, and then the hypothyroidism with pembrolizumab. That's what we expect. So This has already made it into our favorite guidelines. It's already been FDA approved, already something that people are going to be doing, and really interesting to follow going forward. Are we going to see the same relative improvement in those who are cisplatin eligible? This regimen has already replaced cisplatin-based chemo in the metastatic setting. Will it do so in the neoadjuvant setting for those who are cisplatin eligible? And really interesting to see an EV Pembro study versus a neoadjuvant cisplatin study to see what that will look like. So a space that continues to evolve, but improved outcomes for these patients with bladder cancer, especially those who are cisplatin ineligible. You could see some folks, I believe the FDA approval is just for cisplatin ineligible, but some patients, they're gonna see that there are people on the study who just refuse cisplatin, and I think you'll see this used some in patients who are candidates for cisplatin and maybe should get it, although I guess we don't know until we do the study. You will see this regimen used more and more in the bladder cancer space. So that's what I have this week, talking EV Pembro. Thank you so much for listening. You can follow me on X at FarmDeetNib and the podcast on other social media platforms at UncleFarmPod. And until I talk to you again, remember, doses matter.